Shot. Okay, welcome to the Deuk Spine Institute's live stream. We are now starting our third surgery. Shot. And this patient, she comes from Washington. Shot. Oh my God, I'm just so off today. The last patient is from Washington. Thank you, thank you. She's from Naples, Florida. I apologize. Where do you feel that?
Where are you feeling that? In the back? Okay.
Shot?
Just finding the right spot now.
You're doing great. Just give me a minute. We're going to be where we need to be and we can put you to sleep. Shot? All right, so at this point I'm trying to access the disc at 54334 on the left side, AP. We're going to get another view through a front back. I'm going to give you some more numbing medicine, all right? So far, everything's going real well. Don't be alarmed that you're awake. You're supposed to be awake. Shot. All right, back to a lateral. You're doing great. So, I'm going to try to go a little more medial. All right, I'm hitting the facet. Shot. Where do you feel that? In your back? I can't hear her.
She says in the back.
Yeah, that's what I expect. We're right on your painful facet joint. You're okay. Hang in there. We're almost done. In your back? All right, sorry about that. That's one of your bad discs. Shot? Boy, it's interesting. You feel it in your back, right? Is that better? Let's get the next level, Monica. So it's a left 3, 4, 4, 5. Shot. All right, that was definitely a good move. See how off you are on orbit right there with the facets of 4? Or sorry, 5. Superior facets are way off. Keep going, just a little more. You're off on WAG. Yeah, that's better. Definitely making improvements here. I think you're off on WAG by 1 degree. Shot. You went the wrong way. Shot. All right, that's pretty close. Maybe a little more on WAG. Shot. WAG shot. A little more. WAG shot. That's pretty good right there. That's about as good as we're going to get it. All right, so we're just lining our x-ray machine up. Remember, we're navigating. We need to navigate to the bad part. Let's get some num-num. Shot. That was it. Good job. Yeah, go. Go ahead. Inject. Good. Enough. We're giving you more numbing medicine. You're doing great. Just relax. Shot. All right. So you can see I'm approaching her facet. Shot. I'm going to change the orientation of the needle and aim more medial. Shot. Right up against the facet. Perfect. Where do you feel that? Your back? Huh?
Back and where? Feel you in the back? Back.
That's your bad disc, sweetheart. All right, so we've done 2 discs so far. Well, let's go down and show the sacrum just so everybody can see. I need them then. And we're going to do the same 2 discs on the right side, plus we're going to add 2, 3. That's good. That's perfect. So you can see that we're at 3, 4, and 4, 5. Everyone agrees? I've given you some more numbing medicine. And now I'm going to access those discs on the other side. Shot. So we're going to do the same discs on this side. And then we're going to do the one above. Shot. Can you move that cable, please? Why did you... Okay, so you just went south. Is that what it was? Yeah. Mm-hmm. Shot. All right. I need you to get that lined up. Do you see the double shadow on the superior of the L5 facet? Or pedicle? It's a WAG issue. It's not an orbital issue. Monica, it's taking too long. It's a WAG. You're still off on WAG. Shot. All right, still off on WAG, big time. Mm-hmm. There we go. It's better. A little bit more. That's. I think you might have overshot a little bit. Shot. Mm-hmm. All right. So Henry, shot. Let's get a AP at this point. Henry, any questions from our audience?
No current questions, so we do have a comment from Brian Powers on Facebook saying, there's no way I could be awake for this. When I had a myelogram done, I thought I was going to die.
No, you didn't get the side I need to see. Yeah, Mr. Powers, you bring up a great point, and I appreciate that. So to answer your comment, she's not really awake like you think she's awake. She's sedated. She's a bit out of it, but she's still awake enough to answer and talk, but she's not like fully there like you and I are talking right now. Shot? That's it? All right. So she's a bit sleepy, a bit out of it with the medicine, but she's awake enough that I can have somewhat of a conversation with her. Okay, shot? All right, so we are in there. All right. But I appreciate your sentiment. And a myelogram is a different procedure, as you know. A myelogram is a procedure where they're sticking dye inside your thecal sac around your nerve roots. It's a very uncomfortable situation. We're not actually doing that. We're staying in the back of the spine and kind of going around the spine. Shot. Shot. So it's not quite as painful as a myelogram would be. A myelogram would be a more painful procedure. Shot. You okay?
How are you doing?
AP. She all right? Reliable? Yes?
Having any back pain right now? No leg pain?
Perfect. Doesn't get any better than that. So at this point, we've lost about 5 drops of blood. Shot. We're about to enter 3-4 on the right side, which was our next target. Shot. It's perfect. And then we've got one more to go, which is number 2-3 on the right. Everyone agree? 2-3 right? Now let's see if we can do it through this incision. I purposefully made the incision a little higher than I want, but just so I can get up to 2-3. Shot. And use the same incision. That would be ideal. Shot. That's it. All right, so I'm just a little bit, there we go, shot. Too low. Shot. Much better. I'm just hitting her facets. It's her back. Shot. It may be her TP. I may be hitting her transverse process. That's what it looks like. Let's get an AP. I bet it's a transverse process. If that's the case, I may have trouble sneaking around that. You can kind of see it over there on the, looks like a bubble. All right, let's get that. Yep, I'm hitting her transverse process. So I'm probably going to have to do a separate incision for 2-3. Shot. I just don't think I can get around it, but I'm going to give it one more effort. Yeah, it's hitting the TP, and it's deflecting me north. And it's deflecting me so north that I'm not going to be able to get it. So I'm going to just put this third one through a separate incision. Num. It will be a little more medial in the entry point and a higher, obviously. Shot. That's looking good. Shot. What's that noise, Luis? Shot? That buzzing right over my left ear. That's the pressure machine? Alright, just about there. Shot? Huh? It sure is. Where do you feel that, Shot? I feel her herniation. I'm right on it. Yep. All right, let's wake her up and let's test her. Okay, so at this point, we have successfully gotten into the 3 discs on the right side and then also on the left side. So we're doing bilateral because she has bilateral leg symptoms. Now she came to me and she has obviously pain that is primarily legs but also back. She has 3 discs that are damaged. L4-5, L3-4. Can you guys see this okay? Henry?
Yes, we can.
All right. She's got tears on this side at 2-3, on both sides at 3-4, both sides at 4-5. Are you comfy?
How are you doing? You okay? He said yes.
All right. Is she reliable? Awake?
Are you with us? She said yes.
Mm-hmm. Are you having any back pain?
Are you having back pain right now? Yes or no? Any back pain?
Yeah, come south a little, just a tiny bit. All right, no back pain. Now, how long has she had pain for? How long have you had your pain for?
How long has that back pain? How many years? How long? 7 years? 7 months.
It's probably longer than that, but let's just put 7 months, which is good that we're getting to it sooner than later. You comfy? She reliable? Oh, look at that. You can hear her shot. That was, yeah.
What number is that?
All right,
0
show
or
us
10?
the tear.
What number? 10.
10. Is that where you get pain? That is 3-4. Is that where you get pain? Yes, she said yes. So it's concordant. So L3-4 is 10/10. Is it better? I'm sorry. I'm very sorry. But we had to test the discs. You guys could see the annular tear at 3-4. Is it better now?
Is it better now?
right. See her come up? How bad is that on a scale of 1 to 10? 10. Is that where you get pain? That's L2-3 concordant. I'm so sorry, sweetheart. We're going to be able to put you to sleep in about 1 minute. All right? So, folks, what we've done is we've tested 2 out of the 3 discs we're fixing to see if they're causing her back pain, and they are. 10 out of 10, concordant. Concordant means it's her pain she gets every day. Is that better?
Feel better?
How bad is that on a scale of 1 to 10?
10. She said 10.
Yeah, you can see the tear. Another 10. So you get to go to sleep, and when you wake up, we'll be done, sweetheart. Is that where you get pain every day? Yeah. All right, so while we're putting her to sleep, I'll talk to you guys. This patient came with chronic back pain like everybody. I figured out it was based on her exam, based on the MRI and my experience. It was coming from these 3 discs, number 2, 3, 3, 4, 4, 5. If you look at her MRI, the L5S1 is perfect disc, nothing wrong. I didn't think it was coming from there. We just confirmed my diagnosis. She has 3 discs causing her back pain. It's horrible. You saw her arch up when I injected. She started to groan and moan. We asked her how bad it was on a scale of 1 to 10. She said 10 out of 10, all 3. And I asked her if that's where she gets her back pain every day. She said yes. So you wanted to know why the patients are awake. They're awake for 2 reasons. Number 1, in the beginning they're awake so we don't get too close to the nerve root. If we do, she'll tell me she has pain down her leg, and I have to adjust my trajectory. Look at that. Isn't that cool, guys? We didn't inject dye on this side. We injected on that side, but you can see it on this side because it filled the disc. All right, the second reason patients need to be awake is that we need to do a discogram, which we just did. It's a confirmatory test confirming the diagnosis of discogenic back pain. I'm going to move. Henry, why don't you show our audience the video as to why people get back pain from a herniated disc, okay?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, at this point we are now inside the disc. We have 5 areas to repair. This is the first of 5. Oh, by the way, for those of you who watched our earlier surgeries, both of those patients are already gone. The gentleman that we did last, 511, I need laser.
I want that light off, please. Thank you.
He's already gone. The cervical from earlier today gone. And they're both very happy. Their pain is gone.
We have a couple comments.
Yeah, let's read the comments.
This first one comes from Sheila on YouTube.
Hello, Sheila.
And they said, I'm having a decompression on my L4-5 on July 11th after a 4-year wait.
Yeah.
That's it.
Yeah, Sheila, it's not going to fix your problem. I hate to say it, but a decompression surgery is not a good surgery. First of all, there's only a few ways to do it. One is called a laminectomy. The other is called a microdiscectomy. Both of those surgeries are highly invasive. They cause a lot of trauma to your spine, to your body. You'll be in horrible pain. And more importantly, they don't address the problem. The problem that's causing your pain is not compression. The problem causing your symptoms is inflammation. And that's what we're doing here. We're treating the inflammation. So if you want the right surgery for your problem, you need the Deuk laser disc repair. I'm just telling you, okay? Don't shoot the messenger. Isn't that what they say? Don't shoot the messenger. We're not doing a decompression here. We're doing a inflammation treatment. Getting rid of inflammation. That's where her pain's coming from. But thank you for sharing. I hope you'll reconsider your plans. And be my advice for you to do a free MRI review with me and get some answers, so we can talk face to face.
Thank you.
Okay. What is it, Sarah? Whew. Sarah? Are you here? I mean mentally. We know you're here physically. All right. All right. Huh? Oh, okay, no problem. Henry, we're ready for the next comment.
Next comment comes from Brian Powers, once more on Facebook, and they said, following about their myelogram, they said, Brian said, they said I had spinal canal blockage back when I had emergency surgery in '96. So that's why they did the myelogram. Thanks again for answering my comments and questions.
Yeah, no problem, Mr. Powers. So 96, I hate to say it, but we did have MRIs. Maybe they didn't have an MRI where you were, and that's fine, because MRIs back in 96, they were starting to get more popular for spine problems. But where I did my work, we had MRIs, and we were able to pop patients into the MRI scanner and, of course, do a quick MRI. But a myelogram, the problem with the myelogram is it's so dangerous to do, sticking a needle in your spine, but more importantly, if you notice where I put the needle, I'm putting it in the disc. The disc is relatively safe, but with a myelogram, they're putting the needle in your thecal sac, it's called. And the thecal sac is the thing that has all the nerves around it. And the problem with myelograms is you can cause meningitis, which is inflammation of the meninges, and it's very bad with the myelogram. So it's a dangerous procedure. You can get an epidural hematoma, you can get meningitis, you can also get arachnoiditis where the nerve roots stick together, and people get this leg pain that can never go away. It's called arachnoiditis, and it's from scarring of the nerve roots, and it's actually from the procedure, the myelogram. So I never do myelograms, ever. And I realized it was back in '96, which is a long time ago. So back then maybe the hospital and surgeon, they didn't have an MRI to do it with, you know, but thank God we have MRIs now, so we don't have to do myelograms anymore, you know, emergently. But thanks for sharing your story. What's that? Yeah, I'm wondering, yeah, you may have some residual problems from your myelogram. Dr. Berndes is mentioning, he's right. Certainly possible. Again, look up arachnoiditis. That's where the nerve roots stick together. Oh, I've seen so many people with that. And they all had myelograms, you know? They all had myelograms. So thank God MRIs were discovered and have become more common. Man, MRI scans, what an invention, huh? One of the best inventions ever. Thank God for technology. You wouldn't want to do alcohol anesthesia, would you? Laughing yes. All right. Next comment.
This next comment is actually a question. This comes from B3 on YouTube, and they asked, how many of these life-changing procedures do you perform in a day?
Yeah, B3. Today's a busy day, I know. We've gotten consistently busier and busier. The truth is. And people recognize what we can do for them, and they're traveling from all over the place. Now, I had 3 from Florida so far. I keep thinking they're all from Washington, but one of them is. It's the last one. We've got one more to go. How many can I do in a day? Basically, it's a bit of an unusual day, to be quite honest, because not only are we doing, it's a long day. We're only doing 4 patients, but the reality is each patient is requiring an extremely long and arduous procedure. So normally I would see like a patient and do 2 discs, right? Like an average of 2 discs per patient. But today we're doing 2 4 discs or 2 5 spots, and plus on top of that plasma rhizotomy for facet. So it's just unusually long and involved procedures today. We don't normally do this much per person. Huh? Yeah, a lot of combined procedures. Meaning we're doing the disc and the facets at the same time. And again, the only reason we're doing that is because I don't want to make people have to come back and get surgery again. I like to do it all in one shot. It's safer. It's less expensive for the patient that way. It's taxing on me and my staff. We're suffering through it. And so it's, huh? Yeah. Kudos to my team. So how many can I do a day? It just depends on how involved each surgery is, but I say we can tap out or max out at around 4 to 6, but only 6 only if it's like just 1 or 2 levels, not these massive cases. I call them massive. They're not massive from the sense of a big incision. They're massive from the sense of a lot of time needed to do the surgery. So, all right, we're done here. I'm getting out of this one.
Lights on, please. Thank you.
Yeah, today's a long day. Let me have a grabber. Actually, I'll irrigate it out. Scope off. Irrigation. Great questions from all of you.
We don't have a question, but we do have a comment from Brian once more on Facebook. And they said, thank you very much for all your information. I'm from Chicago, and they did an MRI first, then the myelogram. You have a great team, and I've watched you for a while now.
Hey, thank you. It means a lot. And honestly, having you all around here while we're operating, it makes it a lot nicer for us too, because I hate to say it, but sometimes the work gets a little monotonous, doing the same thing over and over again. And like I told you before, surgeons love monotony. They love having that stability where things don't change, right? Where you don't have to worry about somebody having a serious problem during surgery. So as much as I appreciate the fact these surgeries are not that exciting, I also appreciate the fact you're all here asking questions, participating with us, and being involved in the surgery. So I feel really good about this patient because after seeing her discograms, I recognize that all 3 discs are causing her pain, and we've tapped into all 3 discs on both sides on 2 of them. And I really feel good about that because I really feel like we're going to be able to get rid of her back pain with this surgery. So I'm pretty excited for her. And that's what keeps me going, is that knowing that this patient's going to not have this pain anymore the rest of her life. It's going to make a big impact in her life. You know, if I didn't have that to look forward to, I don't know that I could be here for the long hours that I'm here for. Now, I know where I'm going with this is safe because I've already shot. I've already put the needle, remember earlier? And I know that the path of the needle is safe. So once you put the needle in a safe path, then the guide wire goes down the middle of that. You know for sure that you're not going to hurt the patient as long as you don't go in too far. You know you're in the right trajectory. And that's the beauty of this surgery, is that the first step of placing the needle is the most important step of, let's go, basically making sure the procedure will be safe for the patient. So it's kind of nice, you know, with other types of surgery, you can have problems at any time. We can have problems at any time as well, but it's extremely unlikely because in the very beginning, that's where you do the hard part, is navigating the needle. But once you've navigated the needle successfully into the disc, look at that tear right there. That's crazy. Look at that granulation tissue. Right there. I'm going to laser that away.
Thank you.
That's where her pain's coming from, right there. Say goodbye to my little granulation tissue, Oscar. Say hello to my little friend. All right, let's get that herniation out. That's a piece of herniation right there. So what do we do with the indigo?
Oh, we double those.
You doubled it.
Yeah, for this case.
So I don't think it looks that much different, do you? A little bit? I mean, come on, Oscar. I think it looks better because the visibility is better. But I'm not convinced that it's darker blue. Do you think it's darker? Yeah? I mean, it's clearly better visibility than the last case, because the last case we had. You mean from before, yeah. Yeah, you can see the blue dye, guys, is sticking to the herniated nucleus pulposus, which is stuck down to the annular tear. That's a really good picture right there, Henry.
Copy that.
That wall right there where you could see the blue. I wonder if you could get that picture for me. Do like a screenshot later.
Yeah. That'll be up on the special cases folder tomorrow morning.
Yeah, that'd be great. Because it really shows nicely how the nucleus sticks to the annular tear in a sheet-like fashion, holding the tear open. And that's why the disc never heals. Because all this blue stuff is stuck down right here. Just keeping the tear open, allowing more and more herniations to come out. So I'm removing a piece of herniation right here with the laser. For those of you who don't know, that laser fiber is glass, and it's literally 1 millimeter wide. So that gives you a reference point in terms of diameters and sizes. Look at that. Guys, see it? The little metal thing right there?
Yes, we do.
That's the needle on the other side. Can barely make out the tip right there. Okay, remember we're doing a double on this one, left and right. That's the needle from the right side. Pretty cool, huh? All right, you can see the tear, herniation. Yeah, it may be more blue. I'd be interested in trying a few more and just seeing, you know, if there's a difference between the two amounts, Luis, whether you use the 5 or the 10, and just see if it makes a big difference. Because this is the way I like it right here.
Yeah.
And I'm just wondering if maybe they're just putting less of the dye in per milliliter, you know? Despite what they say, that it's the same. This comes from the country that makes fake rice. I'm dead serious. They make rice out of plastic. You didn't know that? They got caught. You guys never heard that story? You heard about the baby milk, right? A couple of years ago? Fake baby milk? Oh man. Fake baby formula? Yeah. Huh? Oh yeah. That's no joke. Man, you got it? All right. Almost done. We're at the end of the disc. You guys see that? We're right outside the disc here. This is the end of the annular tear. What you're actually seeing there, just above the fiber, is the posterior longitudinal ligament and foraminal ligament. So when the posterior longitudinal ligament travels from the back of the spine to the side, it goes out the foramen and becomes what's called the foraminal ligament. That's for neuroforamen. One minute left here and we'll be done. Which side is the DPR?
Your side, left side.
So we'll do this last disc and then we'll do the DPR,
Yes, sir. Okay.
right? A little bit of scar tissue there in the foramen. Any questions?
No current questions. We do have a comment. Well, it was talking about rice. This comes from Canes 25. He said, yes, fake rice, eggs, lettuce, and on our world is being fakes.
Yeah. You know it. You know it. All right, we are outside the disc. And I'm just cleaning up the last bits. I want to make sure this thing heals well. So I'm looking at this stuff, getting rid of the last bits of herniation and any scar tissue I can get rid of. All right. That should do it. Oh, Luis.
Yes, sir.
Our last patient was wondering, can he come in tomorrow morning, 7:30, and get his staple out? Because he's got to catch a flight back to Louisiana. Yeah, the last patient was actually from Louisiana, right? Yeah, he's doing phenomenal. Yep, no pain. He's from Louisiana. This one's from Naples. And the next one is from, where do we say? Washington. Man, I'm bad today. Just got so much other stuff on my mind, but. Have you guys ever been in Naples? It's beautiful. I think that's clogged, Luis. Clogged. Naples, Florida, really nice. Clogged, a little bit. All right, great job. That's nice and clean. We're done on the left with the DLDR. So I'm going to do the DPR, correct?
Yes, sir.
Left side, everyone agrees?
Yes, sir. L4-L5.
L4-5. Come on, bring that forward in. Let's stay in the AP configuration. Let me know when you're ready. You're going to need to bring it up to the top. Up, up, up. Left 4, 5. Wait. Sure, shot. Is that it? All right. So that's 4, 5 there. Wait, do not shoot. She has a little scoliosis, so it makes it a bit challenging. Shot. All right. I need to see my side, Monica. Do you understand? My side. Shot. Okay. Definitely on the TP, I feel it. I need to go a little more medial. Shot. Shot. Is that it? Shot. All right, Luis. That's what we need to numb up. Go ahead. Knife. All right, at this point we're going to perform what's called the Deuk plasma rhizotomy, which is where we kill the pain nerve that is sitting on the facet joint at L4 and L5. Now I picked the L4 and L5 shot, and I could be wrong. I hope I'm not. But shot, there's always a possibility when you're picking facets, shot, that you could be wrong. Is that it? Shot. Huh. So she's got some scoliosis, which makes it a little harder for me. Shot. Man, it looks like kind of an abnormal transverse process, doesn't it? Shot. 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 So you can see the pedicle, and I'm just lateral to it. But it's an abnormal shot bone, very abnormal. It's not shaped normally. Shot. It's pretty damn good. You guys see how small the transverse process is? It's like a little thing. It's insane. I didn't realize how many abnormal transverse processes people have until I started treating this condition more by itself, you know, shot. I'm literally on the edge of that thing, and it's so abnormal. All right. And we're going to go down to L5. Move your hand, shot. I need to see the bottom a little bit better. L5. Shot? Not really, but shot. I can see the TP right there. Shot. Now right on the transverse process, so I'm right where the nerve normally runs, the bad nerve, the pain nerve. So definitely in the right spot. This, you guys see the transverse process here? It's a lot more normal looking. Shot, you guys saw it down there? It's just the L4 transverse process on the left that's totally weird. Even the one above is normal. So, all right, put pressure. Great, we're done with the DPR. We're gonna move back to the endoscopic DLDR, which is the disc treatment on the right side. We got 3 more to go and we'll be done. This will be 30 minutes. Shot. Wait a sec, did that needle come out or not? Shot? No? Shot? Okay. Starting at the bottom.
Yeah.
Shot. No problem. Any comments, questions?
Yes, we have a comment and a question. This first comment comes
Shot.
from Canes25 on YouTube.
Sounds good. Go ahead.
They said, Doc, look up Codex Alimentarius, UN resolution signed years back to backdoor us and GMO on all vitamins and minerals out of food. I don't know.
I don't know that I understood that comment.
I'm trying to understand it too. I'll just
Something about a codex of food or something?
Yeah, Codex Alimentarius, UN resolution signed into law years back to back, door us and GMO all vitamins and minerals out of food.
Oh, right. I think I understand now.
Okay.
Take that. Take it out. All right, so a lot of people talk about how hammering this metal device into the patient is freaky, which I understand, I get it. When I first saw it, I thought it's the craziest thing I ever saw. But now that I've done it for years, it doesn't mean that I've become crazy. It just means that I understand the purpose of it, and it is to deliver energy to this metal tube in a quantifiable manner that's not going to put too much energy at one time.
The patients are deeply asleep, so they have no recall, no sensation of pain.
Yeah, the patients are unaware of it, but until they watch the surgery, and then they freak out again. But from a standpoint of delivering the device into the disc safely, it's the safest way to do it. Grab her. Grab her. All right, why don't you take care of that side while you're waiting, if you can. Luis, take care of that side when you get a chance, if you get a chance. You're going to do staple or suture? I mean, that seems to be working, right? Why not? I mean, what are your thoughts? Because they all come back in the next day, and you can just take it out, and you can put a steri strip. I agree. So just the staple and a bandage. And then tomorrow we'll put on a steri strip. I like it. We're constantly refining our technique here at Deuk Spine by very creative people like Luis, Dr. Berndes, my nursing staff, everybody is contributing ideas to make things better for the patient, and I love that. It's a team approach. You don't find that everywhere. As a matter of fact, I don't remember seeing it all in my training. Everyone is just so to themselves and not really a team, you know? There was really no creativity. You know, I'll tell you a funny story. When I was a neurosurgery resident at the University of Florida in Gainesville, one of my attendings was Dr. Arthur Day. He was preeminent neurosurgeon in the world. There's your tear right there. You guys see the tear? See how the herniation is stuck on it? Anyway, we were managing patients with subarachnoid hemorrhage from aneurysmal hemorrhaging, and we were clipping aneurysms and doing all kinds of stuff like bypass and coiling. We were doing everything back in the late 90s, early 2000s with Dr. Day. And I remember as a resident in 97, we had these patients who had aneurysmal bleeds in their brain, and they would all develop hydrocephalus, which is called a communicating hydrocephalus, where the blood would clog up the drain in their brain that drains out fluid. And you know, you produce 3 cups of fluid a day, and then they wouldn't be able to drain 3 cups, they'd drain 1 cup or 1.5. So they would accumulate fluid within their subarachnoid space. And the treatment back then was to do a lumbar puncture, to go in and stick a needle in their spine, clean up their back, stick a needle in there and drain out as much fluid as you could. But what happened was it would decompress the cisterns quickly, and they could get a subdural hematoma complication. They get meningitis, all this bad stuff. So one day I said to Dr. Day, why don't we put in a lumbar drain and drain the fluid that way? That way you don't have to keep sticking a needle in. And he said, no, you can't do that. Well, turned out that's now the standard of care, right? So, but the problem is, for whatever reason, maybe because I was just a junior resident and an intern, just fresh off the boat, they just didn't think that I could possibly have any ideas. But they kind of stifled creativity. And progress in medicine requires creativity. Not just any creativity, but intelligent creativity. And it was not something that was fostered at my program at all. As a matter of fact, when I began to do the endoscopic spine surgery, after I graduated, I learned from the Koreans and from Germans and Dr. Young over in Phoenix. I went back and tried sharing this with my team, the neurosurgeons that I trained under, and trying to get them to adopt endoscopic spine surgery, but no way. They weren't going to. They were too set in their ways. It's unfortunate. All right, just about done with this disc. Done a nice job of cleaning it out. There's a little more bleeding, you saw that. The bleeding is because we've already done the other side, and the other side still has a little bit of blood that was coming into the disc and coming through the disc and up my side. Remember in the beginning I showed you the blue dye in the needle on the left that from the injection on the right? So we injected blue dye on the right, but we could see it in the needle on the left because it went through the disc and came up the other side. Well, the bleeding from the left side that we already did is coming through to the right side. So it's very common. It's nothing I'm concerned about. But boy, this is nice though. The blue dye is really nice here. I gotta say, Luis, very pleased. It's really done a good job of identifying the herniation. Yeah. Oh, I don't, no, I'm fine. Thank you for asking. It's very kind of you. Black coffee. I'm gonna make some black coffee when I'm done. Literally, I need some coffee. We're just about done here. I've got 2 more discs to do. We're done with this one. Look at that tear, it's massive. Good thing she had this done. I think she's gonna be really happy with the results. This will all heal beautifully now that we've gotten the herniation out. And people ask me, you know, did you get all the herniation? No, we're never gonna get all the herniation, okay? We're never gonna get all the herniation. No doctor can get 100%, and I don't try to get 100%. I've accepted a long time ago we're not going to get 100%. We're going to get at best 80%. Maybe once in a blue moon we'll get 90%. But the point is to get 50%. If you can get 50% of that herniation, you're going to make that patient feel so much better, and it'll last. As long as they don't re-herniate. Done.
Lights on, please. Thank you.
No, that has to be redone.
Yeah.
We have a question.
Of course.
This comes from B3 on YouTube.
Hello, B3.
They ask, how long does it take for the annular tear to heal? Will a new nucleus be produced by the body to replace the dried out or depleted ones?
Great questions, B3. So to answer your questions, it takes 1 year for the annulus to heal, to get to 100%. And the nucleus will never regenerate. The nucleus comes from something called the notochord, which is an embryological structure found in the fetus, and it disappears and becomes the nucleus pulposus. I got this. You focus on your thing. So basically, to answer your question, the nucleus pulposus comes from something found in the fetus or embryo that, once it's goes and becomes the nucleus pulposus in the adult, you can't make any more. So, thing about it though is that you don't need nucleus pulposus. Everyone thinks they need a tall disc, a high disc, a normal disc. You don't. There are millions of people with completely collapsed discs and no pain, no radiculopathy, no symptoms whatsoever, and they lead completely normal lives. So that's really what the goal of treatment is to get people asymptomatic. It's not to make their disc look normal, but there's a lot of misinformation out there, unfortunately, about the disc, and that's what we try to clear up here at Deuk Spine. Oh, shot. Yeah, north, please. You're way off. I mean, you should be farther north. You're way off on the WAG, too. Shot. Shot. Yeah. So what I've done here, I bent the needle going into the disc, and you can see that on the x-ray, and it's just hard for me to get the needle out because it's sticking on the guide wire because of the bend. Anyway, we're getting it. So you just got to be careful when you do this stuff. You got to keep getting x-rays to make sure. Look how bent that is. You guys see that, Henry?
Yes, we do.
Yeah. So it's okay to bend the needle. It's not a problem. But you don't want to pull your guide wire out accidentally before your needle's completely out and you've done your dilator. So just got to keep taking pictures. Come on, Monica. How's she doing?
Great.
So we're done with most of the surgery. We're almost finished. Just got a little bit more to go. So to answer your question, discs do not regenerate except for the annulus will. The annulus is the only part of the disc that can heal. And the nice thing about the annulus is that it's made out of collagen. So when it heals with collagen. So the same thing it's made from. It's one of the only tissues in your body, as a matter of fact, probably the only tissue in your body that actually heals with the same material it's made from, which is collagen and some elastin. Like if you injure your liver heals with collagen. If you injure your muscle heals with collagen. Everything in your body heals with collagen except in your brain, where it doesn't heal with collagen, because you have a blood-brain barrier. Anyway, every other tissue heals with collagen. It turns out the annulus is made out of collagen, so it's kind of interesting. All right, you see the big tear? Let's get the laser in. The grabbers aren't doing anything. I need a pedal. Thanks. You can see the frayed edges of the annulus there. We got this disc and one more to go. How's our last patient doing? Oh, that guy? No, I mean the one that has still yet to go. She must be hungry. Feel bad. Yeah. The one from Washington. the real patient from Washington. Give her a little vitamin H. Oh yeah? Nice. Yeah. Yep. Well, that's how we take care of our patients. We want them feeling good. All right. Piece of herniation coming out. Any questions from our audience, Henry? You can see the tear. All right, so Henry is taken off for a quick potty break, and if you have questions, you can still type them up, and when he gets back, he'll ask me. But you can see the orange spots. That's calcium. That's the development of bone spurs. We call it dystrophic calcification. This stuff is located inside the disc, and it's an indication of chronic inflammation, meaning inflammation going on for a long time. It's kind of pretty if you think about it. If you ask me, I think it's pretty. But it's totally abnormal. Should not be there. Doesn't cause any symptoms. It's just a manifestation of injury to the disc and chronic inflammation. Some people have more of it than others. There's no real rhyme or reason that I know of. I will tell you, you never see the orange calcification in a newly herniated disc, so it kind of ages the injury. Now, she said earlier she had 7 months of pain, but I think that's 7 months of new onset of pain. She's had pain for years, like most people with back pain, and she's just lived with it, treated it with shots. Nothing really worked. And then 7 months ago, I think things got real bad, and it hasn't gone away. So that's why she ended up here, getting her back fixed, which I think she's going to be happy. What a lot of people don't understand is when we fix people's backs or necks, we're not fixing your back or neck so that you can just sit around and baby it all day. It's not like we're fixing it and your pain goes away, but as soon as you get active, it's going to come back. That's not how it works. We're fixing your back and neck pain permanently. So 1 year after surgery, you can go back to doing everything you want to do in life. You can go whitewater rafting. You can go bungee cord jumping. You can go kayaking. You can do anything and the pain will not come back. So we're not just taking pain away, we're giving people back their quality of life. And there's a big difference, right? There really is a big difference.
I'm back.
All right, welcome back, Henry.
Thank you for having me.
Yep, all right, just about done. You can see we're at the back of the disc here. We got one more to go and we'll be finished. So probably 15 minutes, Dr. Berndes.
Speaking of, we do have a comment. This comes from Hans Berndes on Facebook.
Ha! Nice.
And Hans said, world's greatest spine surgeon.
You're the best. I appreciate that. Thank you. Thank you. That's coming from my anesthesiologist. I really appreciate that. All right, just about done here. She's doing good?
Yeah, really well. Great blood pressure, good vitals.
You using the thing?
No,
CPAP, whatever?
easy on next case.
All right. Everyone doing good? That should be it. All right, one more. Little betadine. Irrigation. Let's get that fluoro in. Everything okay? You may have to raise your fluoro a little, I don't know. You guys doing all right over there? Last one. Here's a long one. All right. Go ahead, Luis. What's the next one?
It's a piriformis with a DPR in it.
All right. Shot? Is that it?
I was just checking.
Take? That's fine. She's perfectly capable. Shot? Shot? 5, 4, 3, 2. You can still see some of the dye. It's interesting because you kind of wonder how long does the dye stay in the disc, right? And at least a couple hours.
We have another question.
Uh-huh.
This comes from B3 once more on YouTube. And they asked, have you ever had a patient come back due to a herniated disc? Do you put someone on a regimen to prevent this, such as supplements, drugs, routine exercise, etc.? And does swimming help? If I am lucky to have this done, I will have my life back. I am from Nigeria, by the way.
Oh, hello, B3 from Nigeria. Yes, we give restrictions after the surgery, and those restrictions are no bending at the waist to pick anything up for 3 months, no lifting more than 40 pounds for 1 year, and no contact sports for 1 year. That's your restrictions. Is there an exercise regimen? Absolutely. We do not want you, we want you walking daily with arm swing for 20 minutes twice a day, first 2 weeks. And then after 2 weeks, you increase to once a day for a mile, and try to get your mile under 15 minutes. That is the regimen for therapy. You don't need to go to a physical therapist. Just do it on your own. And as far as reherniation, absolutely, 1% of our patients will reherniate. 1 in 100. So we've done over 1,600 of these surgeries. We've had 16, basically 15 reherniations. So now, we haven't had many in the last few years because people actually are following my instructions and they're doing what they're supposed to do. They're not violating my restrictions. But once in a while I have people that do violate the restrictions and they do have a reherniation, but it's rare. As long as you follow my instructions, you won't have a reherniation. The people who reherniate from this surgery always reherniate in the first 3 months, and it's always because they lift something too heavy or they bend over and pick things up. They all say the same thing. Oh, I heard a pop in my back. I felt a pop in my back. A pop, like a loud pop. And that's the reherniation. Of course. But the people who follow the instructions, they never reherniate. Nice. Remember that earlier case? My gosh, we fought that herniation for a long time. Remember that? Yeah. 2 levels, 1 side, and then DPR. Well,
We need to order stools, like a bar stool.
yeah, get it. We need not bar stools, we need a massage stool so that we can sit down and get a massage while we're operating. By the end of the day, we need a foot massage, a back massage, right? Oh yeah, something you guys don't realize maybe is that we all wear lead here in the operating room. Lead is lead. It's a lead apron, a lead gown. It's very heavy, and it sits on our back and shoulders all day. Because when we're this close to the radiation machine, the X-ray machine, we have to protect our bodies. So you're right, I didn't even think about that. We're sitting in lead all day. It's very, very heavy. All right, I got 5 minutes. We're done. So folks, this is our last chance to get some questions for the surgery. I'm going to have Henry end the broadcast. We're not going to do the typical QA because frankly we're all peaked and we need a break. So if you have questions, ask them now. We do have one more surgery today for those of you who are really diehards. We got one more to go. And we'll be back answering questions.
This next one is a comment. I believe they're seeking for advice. This comes from Myra on YouTube.
Hi Myla, welcome to our broadcast, live stream from Deuk Spine.
And I apologize. Their name is Mario. Apologies for that.
I'm sorry.
Yes, no, they said it in their description. They said, hello, my name is Mario from Los Angeles. I'm 35. I've had chronic back pain for 15 years. My back pain keeps going out / spasms for about 3 times a year. I'm told it's caused by my herniated disc, but I have no sciatica.
Hi Mario, you do not need sciatica. We can fix your back pain. We can fix it as soon as you come here with this surgery, Deuk laser disc repair. Okay? So come on over. You can do an MRI review if you'd like. Just submit your MRI for me. 1 minute. Just about done. Yes, we can fix your back pain. It is coming from the herniated disc, and this is the perfect surgery. It's done with a small incision, outpatient, no hospital, no fusion, no blood loss, very safe, very effective. No, we're done. How much you have left on that bag? That's fine. We're done. This is it.
We have one more question. This comes from Teak on YouTube.
Hello, Teak. Welcome back.
And
Is that Teak Baker?
I think so. It just says Teak on YouTube, and they just asked, is Dr. Berndes with you today? You guys are a great duo of physicians.
Yes, Dr. Berndes is still here. He hasn't ran away yet. Dr. Berndes loves what we do. I don't think he's going anywhere. 2 years? Has it really been 2 years? Man, time flies when you're having fun. Yeah, Berndes is right here. He's actually gotten really good at doing these surgeries. And we've been kind of pioneering a new way to do them using CPAP machine, which really helps keep the patients well ventilated during the surgery and cuts down any kind of obstruction of the airway. So it's kind of neat. I don't know why I'm having so much trouble. All right. All done. Hope you enjoyed the surgery. Great to hear from you, Teak. Can't talk about that. So today we're using some staples just because we want to try this out and see how it works. And we'll get them out tomorrow when the patient comes to us for their post-op check. Great work, everybody. You can see we had to do 2 little cuts. Thank you, everybody. Good work. And we'll be back in 30, 45 minutes for our last surgery. It will be our shortest one, thank God, on an otherwise very long day. All right. Good job, everyone. And Henry, if you want to just end the feed, you can.